Yes. So I've started your timer and here is your question. Right. So if you have read and understood,
Yes,
considering it
I'm
critical
ready.
care scenario, please tell
Yes.
me how would you manage this patient?
Yes, ma'am. Firstly, I will manage this patient according to ATLS protocol, according to
Good.
APCD approach.
Yes.
The first one and the most important is protect the airway and make consideration in the presence of airway, any inhalational injury or
Yes.
airway edema, considering intubation if there is impaired airway or breathing. The second one is breathing and ventilation. If there is any circumferential burn or tracheal burn, can impede ventilation perfusion match. So I will consider the search for that. The third one is circulation to secure two wide bore cannula, considering Wallace rule of for fluid replacement in this patient by
can you please tell me how much oxygen would you give?
100%.
Okay, good. Would
Yes.
you intubate this patient?
If there is a
Right
patient
away.
risky airway and
Has
inhalational injury,
difficult
airway
complaints of difficulty of breathing, and you can see the
according to the
soot
pulse
in the
oximeter
nostrils.
oxygen,
Yes.
according to pulse oximeter oxygen saturation and the APG or VPG blood sample, we can considering if the airway is not secure, considering intubation.
Yes. Where are you going to manage this patient?
Where?
Yes, where?
In ITU.
Okay. Why not in burn? Would you send the patient to the burn unit?
May send, but initially in ITU, then shifted the patient to the burn unit.
Okay. Can you please mention few indications for the transfer of patient to the burn unit, please?
Yes, if the burn is more than 10% in a child or more than 15% in adult patient.
Yes.
And there is in the genital area.
Very good.
In the airway.
Face. Yes.
In the airway. Yes.
Yes. Good. Can you mention few some formulas or ways with which you can calculate the area of burn?
Yes, initially, according to Parkland formula,
very good.
We multiply 4 by percentage of total body surface area.
Yes.
By the weight of the patient, and will give crystalloid only by dividing the amount of fluid by 2 halves. The first one in the first 8 hours, and second one in the 8 hours. Avoid giving the patient colloid to avoid paradoxical augmentation of the extravascular space or third space by oncotic pressure of the colloid.
Okay. What would be the renal support that you'll give? How much would be the maintenance fluid?
Maintenance fluid?
Yes. How much would how would you calculate it? How much would you give to this patient, considering patient is 70 kg of weight?
By 70 kilogram. The maximum weight to multiply is 60, and the percentage is about 50.
Okay.
So
what are the criteria, or what are the things that you'll assess when you have to calculate the adequate amount of fluid therapy for this patient?
I will assess. Yes, I will assess by firstly cardiac index parameter in form of capillary fill, peripheral warmth, urinary output,
Good.
and the capillary fill and pulse, and urine output. The second one is central venous pressure. The third one is hematocrit.
Yes.
The third one is core temperature in form of the rectal one.
Okay,
Rectal
good.
temperature.
Can
Yes.
you please tell me what are the complications that you can expect in this burn patient?
Yes, in this patient, the face trunk early hypovolemic shock and maybe delayed infection. Also, in
Yes.
this patient, ARDS, acute respiratory distress syndrome, or pulmonary edema,
Okay.
and the inhalational injury. Also, it is considered inhalational nostrils and face.
Okay. Can you please tell me what is Berlin's criteria?
What is?
Berlin's criteria.
Can we pass this question? I don't know.
Okay. If you'll do the chest X-ray of this patient, what do you expect to see?
ARDS, acute respiratory distress syndrome. Yes. In view of diffuse
Can you
infiltrate of
explain?
pulmonary.
Yes.
Yes, diffuse infiltration of pulmonary of lung, bilateral infiltration of the lung, indicating interstitial edema of the lung.
Okay. Can you please tell me what is ARDS? Can you define the term? You
Acute
mentioned it. Yes.
respiratory failure, non-cardiogenic pulmonary edema, characterized
Okay.
by hypoxemia that with decreased lung compliance, refractory to oxygen supply.
Can you
Characterized
mention some complications associated with ARDS?
ARDS
Yes, please.
complications
Yes, please.
in form of interstitial lung disease, pulmonary fibrosis in the later,
Okay.
hypoxemia,
Yes.
infection, super added infection, and leading to
Okay.
sepsis and
Very
sepsis
good.
syndrome.
Very good.
Yes.
Okay. Can you please tell me what can happen in a patient, in a burn patient who has ARDS for a longer time?
Yes, as regard early that will be started by as regard the pathophysiology, there is a disorder or a disintegration of the endothelium of the capillary, leading into shift of protein, rich protein fluid into the interstitial area, attracting more neutrophils and extensive release of cytokines. After that, also the alveolar basement membrane or epithelium will be damaged, leading to sweep of the fluid into air spaces, leading to impaired ventilation perfusion mismatch. After that, later reparative phase, if no improvement, will be disorganization of the collagen with stiffness of the lung and decrease the lung capacity and oxygenation.
Is it possible for you to calculate the area of burn? It says second degree burn, but then how much, like face, trunk, how much burn?
According to Wallace rule, the head is about 9, both arm in front and back about 9, trunk and abdomen front is about 18, and the back of both trunk and the abdomen is 18. Both lower limb, each one is 18 in front and back.
How much
and
would that be?
1.
Yes, can you calculate and tell me how much would it be for this patient?
In this patient?
Yes, please.
Yes, just a minute. 5, 36 and 36, 45, 45, 54, 54, 63.
Approximately. Okay. Can you please tell me what would happen to the lung compliance in this patient? Burn patient.
Yes, as regard the lung, decrease the compliance. I mentioned before.
Yes, very good.
Decrease
What
the lung
about
compliance
the VQ mismatch?
Ventilation perfusion mismatch. Yes.
Will occur. Okay, very good. All right, well went and excellent, good. Except for the small questions. You have
management.
to, yes, if you read ARDS, then you will know what is Berlin's criteria. It is used in the management of ARDS.
Yes, I still have another steps for management for this patient according to ARDS. in form of the
Okay.
criteria of respiratory support. I will give
Yes.
the patient low tidal volume, medium beep, and high frequency oscillation,
Yes.
and also give the patient manage a patient in prone position, inverting the ventilation in regarding increase in inspiration rather than expiration, and
Yes.
also considering in resistant or refractory hypoxia external extracorporeal membrane oxygenation.
Very good.
Also medication, I will give the patient low dose of steroid, inhaled nitric oxide, antibiotic and infective cause. And
Yes.
also regarding hemodynamic and instability, hemodynamic support, I will consider support the patient in maintenance fluid, low CVP pressure to decrease the pulmonary microvasculature. Also, the last part, nutritional, will be initiated 48 or 72 hours after ventilation to decrease bacterial translocation, considering giving the patient fatty acid in form of linoleic and the benzoic acid as a vasodilator, anti-inflammatory, and improve the recovery of the patient. This is the remaining of the management.
Remaining of the management. I actually, when I interrupted you, I realized you know it very well. That's why, this can happen in exam as well. Thank you. Question. If you have read and understood, kindly begin your examination session.
Okay, I will start by washing my hands and introduce myself. Hello, I am Dr. Muhammad, the treating doctor of today. May I confirm your name and age, please?
I'm John, 55 years old.
Nice to meet you, Mr. John. Today you have been asked to examine your lower limb. This will include looking and feeling and doing some special tests. Are you okay with that?
Yes.
Okay, do you feel any pain at the moment?
No.
Okay, please, if you feel any pain at any moment, tell me to stop examinations.
Okay.
I will start by I also should expose all the patients from the abdomen, all the abdomen and his lower limb, and then start by looking by inspections. I will look for the distributions of the varicosity, if it is in the in the distribution of long softness or short softness, and if there is any if there is any signs of chronic venous insufficiency, like venous eczema and hemocytine depositions or ulcers or venous ulcers. I will also inspect for any scars of previous scars of previous operations. It may be by looking at the medial malleolus and the saphenofemoral junction, and look for any lower limb edema. Then I will start by palpation. I will help the patient to sit down, to lie down on the couch, and then starting palpating the saphenopharynx. As in and then also assess the temperatures by the back of my hand and compare both sides and the distributions of the varicosity, and also then palpate for any tenderness over the site of varicosity, or and then doing the special test. I will start by doing the Trendelberg test. By doing the Trendelberg test, and if it is if it is positive, this indicate the saphenofemoral junction incompetence, and then I will do the tourniquet test by above and below the knee, uh, uh, and I tell the examiner that I couldn't locate their site because I have only one tourniquet. Then I will offer that to do the Persis test, but which can be done by the complete occlusion of the superficial system, but it can't be achieved due to the presence of, but can be achieved in the examinations. As in by the stethoscope, by the Doppler, assess the cephalofemoral junction by the Doppler, and to complete the, and offer to do the arterial examinations and abdominal examination.
Okay, how would you do the modified Perthes test? What would you see in this test?
Modified versus
Yes.
modified versus should be done by occlusion of the superficial system.
Yes. With tourniquet.
By a tourniquet, and
Yes.
then, and if there if there is occlusion of the deep system,
Yes.
there will be a pain. The patients will feel a severe pain.
If it is positive, what would you interfere? Would you interpret?
If it is positive, there will be a closure of the deep system, and there is
Then if it's positive, then there is secondary varicose veins.
secondary. Okay.
Yes, and if it's negative, then it's primary varicose veins. Okay, can you present your case now, please? Are you done with the examination?
Yes.
So you can thank the patient, ask the patient to dress up.
Okay, I will.
Wash your hands.
Okay, yes, I thank the patient and help him to
Dress
put
up,
in his
yes.
clothes, yes, and then wash my hands again.
Yes, and can you please present your case now?
Yes, today I have been examined. Mr. John, 55 years old, came complaining of varicose vein in his lower limb.
Yes.
By inspection, there is varicosity along the distributions of the long saphenous vein, and there is also there is multiple incompetent perforators above and below the knee. There are some signs of chronic venous insufficiency in the form of lipidometal. No, there will yes, as in the form of venous ulcer and venous eczema, as there is no scar of previous operation, and there is no lower limb edema. The saphenous varix is not palpable, and there is no tenderness over the site of varicosity and the perforators. By doing the Trendelenburg test, it was positive, indicating saphenofemoral junction incompetence. And also, I did the tourniquet test above and below the knee, which reveals the presence of multiple incompetent perforators. But I couldn't locate their sites with one tourniquet. By the Persis test couldn't be done because as the complete occlusion of superficial system can't be done. And
what are your main differential diagnosis?
My main differential diagnosis is primary varicose vein with incompetent
Why primary?
Why primary?
Yes, please. Patient is alcoholic and patient is smoker as well. So why have you decided to call it primary varicose vein? What are the differences in primary varicose veins and secondary varicose veins, and how the examination differs? What investigations would you do?
Investigations, I will do arterial duplex and CT angiography. And
why
also
not venous duplex?
No, sorry, I will do venous duplex, yes, to detect
yes.
check the deep venous patency, and
yes.
and I will manage the patients by giving the patients by the improvement of the quality of life,
Yes.
by doing minimal exercise, leg
Yes.
elevation,
Yes.
avoid long standing,
Yes.
and wearing a stocking. And if failed, I will go for non-operative surgery,
Yes.
a non-operative invasive
Yes.
invasive mechanism like radio frequency ablations and sclerotherapy.
Yes.
And if failed, I will go for venous stripping after checking the patency of the deep veins.
Okay, good. Thank you.
Thank
All
you.
right. You started off very well. You did the inspection very good. But then in palpation, do you remember if you missed anything?
Palpation.
Yes. Did you miss anything? Yes. For palpation, you have to palpate the varicose veins, and then in that one you have to look for the temperature, tenderness, blowouts, Schwartz test, low limb edema. You have to look, and then you have to also look for splenaverics. If there is a thrill, if it's impulse on cuff, if there is pulse, if there is compressibility, then you
Yes.
can go on to the special tests like Trendelenburg and modified Perthes test and tourniquet test and handheld Doppler, etc. So you just missed the splenaverics part
Okay.
and the test for varicose veins. You did not do the blowout. You did not do check for the edema and the Schwartz test. So these are the small things. And then you have to read and tell me what are the differences. Like you should know what should be the positive findings in your examination if patient has primary varicose deficiency, and what should be the findings if patient has secondary varicose deficiency. And then you must look in the history. Like in this one, patient was alcoholic and smoker. So it cannot be primary. When is it primary and when is it secondary? So you have to know the causes as well.
Okay.
Thank you.
Thanks.
And here is the question. Right. So if you have read and understood, considering its surgical optimization, please tell me what are you looking at? Can you identify the
Hello?
bone? Yes. Can you please identify the bone in front of you?
Yes, it's a lumbar vertebra.
Okay. This one. And what about on the right hand side? Can you identify the, yes? All right. Can you please tell me what are the differences between the lumbar vertebrae and the thoracic vertebrae?
Yes, the lumbar vertebrae it has a kidney-shaped body.
Yes.
And the vertebral foramen is triangular in shape. Also, the spinous process is short and hatchet shaped. and the transverse process is long and has accessory process on each posterior surface.
And in thoracic, there is
Thoracic.
what is extra or the typical features of the thoracic vertebrae? They have the facet for the
Oh.
ribs.
No,
Sorry. Okay. What more can you tell me? What are the ligaments which are attached on the vertebra? From what are the ligaments which are attached here from inside to outside, please? Can you see the cursor from here to outside? Can you please mention the ligaments, all the ligaments?
yes, the ligament as a supraspinous ligament, and
Just tell me. Yes, I'm listening. From inside to outside. Okay, you learned this. This is your homework. Can you please tell me what passes? What is this? If you can identify this, what is this hole?
hello?
Yes. Can you hear?
Yes, ligamentum flare.
What passes through here?
Yes, spinal cord.
Anything else?
Um,
You have to tell the whole answer, otherwise.
yes. Okay. The root of each the root of each spinal nerve, and the dorsal root ganglia, and the spinal artery of and the transforaminal ligament, and the recurrent meningeal nerves, and the communicating veins between the internal and external plexus.
Anything else?
No.
And the coverings? What are they called? From inside to outside? Covering around the spinal cord? Okay,
Covering?
can you?
Yes, from inside.
I want you to tell the name. I don't want to mention the name. Okay.
Dura.
Yes, please. At what level? Yes. At what level would you do the lumbar puncture?
Lumbar puncture at L1.
L1.
No, sorry. At lumbar puncture at.
Okay. What are the layers that a needle passes from outside to inside?
Passes through, yes, sorry, the lumbar puncture is at L4, L5, and the layer to pass through from outside the skin, subcutaneous fat, fascia, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura mater, arachnoid mater, and CSF.
Very good. Okay, can you tell me what is the anatomy between two vertebrae? There is what?
Between what?
Two vertebrae, one and then another. There is a disc. Can you please tell me the anatomy of intervertebral disc?
Yes, it has an internal nucleus pulposus surrounded by fibrocartilaginous annual
fibrosis. Can you tell me what type of joint it forms in between two vertebrae? What type of joint is formed?
Secondary cartilaginous joint.
Very good. Okay, can you please tell me what are the movements which are present or can occur at lumbar vertebrae?
Is flexion, extension, and lateral flexion.
Yes, and axial rotation as well. Okay, can you please tell me, right, if you can please tell me which vertebrae are these? A, B, and C, please. Can you identify the vertebrae?
B is the spinous process, and A is a transverse process, and B is the body.
Okay. What is D?
The second one, A is.
In the first one, what is D, please?
Sorry, I see the image in the half. Okay, the first one B is lamina.
Okay, D.
D,
D.
pedicle.
Okay, can you please tell me in the C picture what passes through A?
Is
Can you tell me the features of first cervical vertebra?
yes, the first cervical vertebra has no body and no spine.
Yes, and how is it
Uh,
different from second vertebra? Second
the second
cervical, yes.
second cervical, which is axis, it has a body. It has which project upward, form odontoid process,
Okay.
and also thick spine.
Yes, what are the ligaments which are attached to the odontoid process?
As the apical odontoid ligament, and the apical odontoid, there is a ligament attached to the odontoid process.
There are three ligaments, yes.
Yes, apical odontoid ligament and alar ligament and the transverse atlantal ligament.
Okay, good. Can you tell me, please, why the first spinous process can be felt?
The seven.
Yes, first one. Is
The
it
first
felt?
spinal process. Yes, it has a long spine, long vertebral prominence.
Which one? First one or the
T7,
second,
T7.
seventh one? Yes,
T7.
seventh. I asked you for the first C1.
For the C1, how can it be felt?
If it is felt.
If it is felt?
Yes. Can you feel it?
It is felt. No, I don't. But
No. Answer is no. You were asking like I asked you in the other way, ironically. Okay. Can you please tell me which ligament is attached here?
Where?
In the upper spinous processes.
And the upper spinous.
Of cervical vertebrae, there is something called nuchal ligament.
What?
Nuchal ligament. So it's
Nuchal ligament?
Yes.
Okay. And for the A will pass the vertebral artery, right?
Which one?
The vertebral artery.
For the B is lamina, yes. The vertebral foramen and D is pedicle. And then, yes. Basically, I've asked you all the questions. Yes. At what level pyometer ends?
At what level? What? Spinal cord?
Pyometer ends, because these are the coverings of the spinal cord, you know. The most inner one is the pyometer. It ends where? At what level?
L1?
No.
I don't.
You're
know.
talking about the spinal cord. I'm asking about the. Okay.
Pyometer?
Yes, I'll show you. Yes, fine.